All right. So we've basically summarized the previous drug classes, and so now we're going to talk about some new drug classes, all of which are immune targeting or immune altering, and all of which will contribute to the reduction in the pathophysiology of asthma. And so none of these drugs are really kind of frontline therapy. The frontline therapy are the drugs that we just talked about, the beta-2 agonists, the muscarinic antagonists, and corticosteroids, primarily inhaled corticosteroids. Excuse me. The first group, the first group of drugs I want to talk about are called mast cell stabilizers, and the prototype here is cromolyn, also known as chromoglycic acid. This is derived from a plant. The mechanism of action is kind of weird. There's 3 or 4 mechanisms that are out there. We still don't know exactly how it works, but we've got evidence to support all of these claims. And so we do know that it prevents the release of histamine, as it's listed there, particularly from mast cells, which is why it's called a mast cell stabilizer. It does affect the chloride channel, and it has been known to alter the expression of the chemotactic molecules that basically govern immune cell migration. This drug is administered up to 3 times a day. And it's best used as an alternative, but not a preferred medication for this group of patients that have mild to persistent asthma. There's a chart at the end of this lecture that defines what mild, persistent, and some of these other clinical descriptions are for asthma. And they can use, cromolyn can be used as a preventative treatment for patients that have either exercise-induced asthma, but more often for patients that have this unavoidable exposure to known allergens. And so these are the patients that have asthma that's really kind of exacerbated by pollen, specific types of weeds. And so this is kind of like a seasonal type of effect where there's something in the environment that just kind of keeps precipitating this antigenic response, this allergic response, and that basically exacerbates asthma. Interestingly, there's really no effect here on bronchial tone. There's going to be no change in airflow. It's really just kind of preventing the immune complexes and the immune processes that get stimulated in response to this known allergen. What's kind of cool about this drug is that it's virtually side effect free, which is great because you can use it in kids. However, in terms of potency, it's not really that potent. There are other drugs out there that are a lot stronger that can actually have a more beneficial impact on treating asthma exacerbations. And so those drugs would be drugs that would actually alter the leukotriene pathway, which is shown here. And so basically this is going back to biochemistry. Basically, your arachidonic pathway feeds into this leukotriene pathway. And these leukotrienes have major roles in terms of chemotaxis of granulocytes, okay, as well as the production of edema, bronchoconstriction, as well as eosinophilia in terms of the smooth muscle. All right, and so there's tons of different leukotrienes out there. There's 2 main drug classes within this cascade. Your 5-lipoxygenase inhibitors, and so the 5-lipoxygenase is this enzyme that's basically essential for the early phases of arachidonic acid conversion into the leukotriene pathway. And then, so this will be going after the ligand, and then the leukotriene subtype B4 receptor antagonist, and so then these would inhibit the chemotaxis, excuse me, that occurs, and so this would be inhibiting the ligand, and then this would be inhibiting the receptor. Okay. And so the 5-lipoxygenase or 5-LO inhibitors basically Xylitol are under the brand name Zyflo. And this is kind of a mechanistic approach. And so here you're going to prevent all leukotriene synthesis. There's no effect on the receptors, only on the ligand or the ligand, depending on what part of the country you're from. And this drug category is orally administered, and it has liver toxicity associated with it. So, patients have to be routinely monitored for liver function and overall liver health. The second group of drugs are your leukotriene modifiers, or sometimes called your leukotriene antagonists. And basically, because they're leukotriene antagonists, those specific letters are underlined, and that's where you get the suffix cast, montelukast, zafarlukast. Oops, sorry, I went too fast. Okay, and so this is again inhibiting a G protein coupled receptor, and you know how those work. The specific leukotriene receptor is the LTB4 one, but this LTB4 pathway can either induce or stimulate a whole bunch of problematic physiologic processes that really contribute to asthma progression. The movement of granulocytes to the inflamed bronchi, it can alter or stimulate secretions within the bronchi, as well as affect mucus production as well as edema. All right. These drugs can block this receptor. They're quite potent, they're quite efficacious, and they're okay to use in children, so that's beneficial. So montelukast is under the brand name Singular. You've probably heard of it if you are or know somebody who's an asthmatic. Okay, and don't really get hung up on the specific receptors that are involved. We just kind of loosely call them leukotriene receptor antagonists. Don't get hung up really on the biochemical distinctions because there's a lot of different terms for these receptors depending on what part of the world or what part of the country you're from, and so it's kind of crazy in terms of how these specific receptors are defined. Montelukast will inhibit bronchoconstriction. It'll do so by inhibiting a specific leukotriene receptor, and so you can use it in patients that are over 1 year old for seasonal allergies, and you can maintain asthma symptoms. But there are CNS effects, and so when you think about giving this drug to children or even adults that have some CNS type of effects, specifically suicide ideation. So if there's underlying depression, if there's hallucinations and tremor, these are the main kind of problematic side effects. And of course, in terms of having a CNS effect, there are some clinical trials for the use of this drug in Parkinson's disease to reduce some of the associated brain inflammation that occurs. And so there's definitely a CNS effect there, and it's quite potent. So montelukast can be used in patients 1 year or older. Zafarlukast essentially is the same thing, but for a little bit older patients, they have to be 7 years of age or older. And they're essentially equally efficacious in adults. Okay, let me slide this over just a little bit. Here we go. All right. And so basically this is looking at the leukotriene pathway and how T cells become activated. And so there's obviously a whole host of immune cells that kind of play into how leukotrienes govern movement and migration. And you can read this figure diagram here, which is really from a nice review published in Nature back in 2004. Yeah. All right. And so the other group of drugs are your methylxanthines, and these are theophylline, theobromine, and of course caffeine. In terms of methylxanthines for asthma, we're really going to focus on theophylline. It comes in a sustained release formulation, and this is a relatively good bronchodilator that has some mild anti-inflammatory effects. Okay, and so it actually has 3 mechanisms of action, which we'll go over in a second, and it also is known to be a drug that has a narrow therapeutic index, which is extremely clinically relevant, and we'll talk about in the next slide. Okay, so mechanistically, this is a phosphodiesterase 4 inhibitor, so we'll see higher levels of cyclic AMP or cyclic GMP, depending on the tissue, and here you'll see a reduction in the pro-inflammatory cytokines or chemokines in the smooth muscles. We'll see an inhibition of cell surface adenosine receptors. Remember, adenosine modulates adenylyl cyclase activity, and that causes contractions of smooth muscle, so we'll inhibit that process. And the third mechanism is we'll see enhanced histone deacetylation. Remember, acetylation of key histones is required for gene transcription, and so here's a mechanism that's kind of similar in concept, excuse me, at least to steroids. All right, and so you can use theophylline for asthma, for various bronchospasms, as well as COPD. Okay, so let's hold off here and let's make a new recording on the special topic of narrow therapeutic index.